We are on. Okay, so I'll get going. Good evening, friends, and thanks for joining on this online discussion. And to the topic, as you can see, is on stroke in COVID-19 patients, and it's from the Epicenter, Spain. All of us know in news that Spain has been facing a huge challenge. And it's a pleasure to have Dr. Marc Ribo with us, who is going to talk about the challenges and the recommendations for management of stroke patients in this disorder. And we have also got a panelist, Dr. Kittipong is from Tokai University in Japan. Dr. Rajsrinivas, Parthasarathy, I think everybody knows. He's a stroke neurologist and intervention neurologist in our center in Artemis Institute of Neurosciences. And myself, I'm a neurointerventionist. And the session will follow by a question and answer session. I hope it's fruitful and useful for you. Rajsrinivas.
Thank you very much, Dr. Vipul. So I'll start off by introducing Dr. Ribo. He's an interventional neurologist at Barcelona, and his main focus is his research is on telemedicine, pre-hospital and hospital workflows, aiming to shorten times and increase efficiency in acute stroke care. He is a co-PI for RACECAT, and he has done a stroke fellowship at University of Texas, Houston. Coming to the panelists, let me introduce Dr. Kittipong. He's a consultant neurosurgeon in Tokai University, Japan. He is trained in neurovascular field by Prof. Rajsrinivas at Bicêtre Hospital, France. And his main interest is anatomy, and he has done teaching within Japan and abroad. Thank you very much for being here. And so we will go ahead with the presentation by Dr. Ribo. Dr. Ribo.
Okay, so it's a pleasure to share with you our unfortunate experience during the last weeks. We never thought we would face such a situation. Fortunately, it looks like the worst was through, but we're not sure still. And so in my presentation, I will shortly introduce you to our usual system of care, in which you're going to see that we are very organized and very well known, because we thought that we can control everything and measure everything and control the flows and the workflows with good databases. And then the second part, you will see all the changes that we had to take because of this epidemic. So our system of care is based on this area of Spain, which is called Catalonia, 7.5 million people with this incidence of stroke, which is pretty normal. And we have just for some details, this is the cost per patient at hospitalization, 7,000 euros per patient. And if you look at the recommendation of the European Society of Stroke, those are the recommendations. The target should be 3 stroke units per million, or 1 comprehensive stroke center per million. These rates of thrombectomies and thrombolysis, 18% and 5%. This is the target recommendation. And I'll go a little fast through this. And the ideal target will be, and I always say that, ideally, every system of care should be treating with thrombectomy between 150 and 200 cases per million inhabitants. So if your hospital covers 1 million, this is the number of thrombectomies that ideally you should be doing in your center, anywhere. So in our region, all the thrombectomy centers are in the city of Barcelona, which is the capital. You see, we have very well organized drip transfer systems. Wherever your stroke occurs, you will be taken to the same hospitals. And we are just starting 2 thrombectomy-ready centers. These white and purple centers are thrombectomy-ready centers in which you can get a thrombectomy during from 8 to 8 every weekday. So with these numbers, we comply with the recommendation of the European stroke organizations. We are within the same numbers, and we have a very good registry, mandatory registry, in which we include all stroke codes that happens in our geographical area. As of today, this is the numbers, the full year, last year, the full 2019, we included almost 7,000 stroke codes, and you can see that we end up treating over 1,000 thrombectomies last year. Again, now I'm finishing with the historical view, but year after year we increased our numbers, and you can see how the red regions are spreading over time. So we increased our stroke code numbers and the vascular treatment numbers. We were doubled in the last 4 years. So we are still need to do things better, but just to show you the degree of detail that this registry has, we can know by town in the geography, in the map, in which towns there were activations and how many patients were treated in this specific town with IVTPA or endovascular treatment. So, this was just as an introduction, and as I told you, we were proud of these organizations and well known because apparently it worked very well. So what is happening in the last couple of months after? Again, we heard all this news coming from China. We thought that was something that was happening far away from us, and like other epidemias, it will never get to us. And initially, it was just a story that we heard on the news initially. But now, again, since the beginning of March, we have our president on TV every single day. He's giving a message. Well, I'm not talking about his popularity because probably it's going lower and lower every time because people are, anyway, let's skip this part, but it became a really, from the beginning of March, a really real concern here, and to the level that you can see how around after the first week of March, the numbers of infected people started to increase exponentially. We are at the yellow line, which is our region, Catalonia. The worst part of is happening in the area of Madrid, which they have even higher numbers of infected people. And you can see in relation to other parts of the world, which are really bad, the numbers look worse than in China, and well, in the same line as north of Italy, and even it looks like in New York the numbers seem to be worse, even worse. Anyway, this is what we should expect according to predictions in the number of deaths. So we're still in the steep part of the curve, steep increase, and it looks like it's gonna keep growing until the beginning of May. So around 3 additional weeks, we're gonna have day after day an increased number of deaths, and so. This is what we should expect. So what happened in the hospital? I work in one of the largest hospitals here. We have around more than over 1,000 beds in our hospital. And initially, at the beginning, second week of March, when we saw that the number was increasing, we decided that all the neurologists, we will stay at home as much as possible. Same for interventionalists, and only a limited number of people will go to the hospital and expose themselves. The INRs would only go to do emergent cases. So we unscheduled, we canceled all other cases that were scheduled. Non-acute procedures are not done anymore for the last month. That will mean that we will have a waiting list probably. Well, not probably, for sure. We will have a waiting list for non-emergent cases that is growing day after day. And the number of admissions progressively increased. And we started occupying wards in the hospital with COVID patients. We started, and basically we started in the top floor, and progressively they went down. So all other patients we tried to discharge them, send them home, or transfer them somewhere else, even to other hospitals, if you were a patient with COVID negative. So basically, for the last 3 weeks, 85% of the hospital is filled with COVID positive patients, meaning that all other specialists are, how would I say? Well, they changed their practice. Now they work in collaboration with internal medicine and infectious disease doctors, seeing COVID patients, or they remain at home. And except for one part of the hospital, which is still COVID negative, and this is basically the stroke unit and the coronary unit. Here is the only part of the hospital that is that was respected as a non-COVID, and we managed to still admit our negative patients here. But what is happening now? There were not enough beds. Some hotels in the surrounding of the hospital were transformed into hospital wards. And now we have COVID patients in these hotels around the hospital. Those are usually the less severe patients, which are sent to the hotels, or those in which we do not expect they might need an ICU bed or an intubation. And because this was not enough, also they transformed a sporting facility that is across the street from our hospital, in which usually play basketball games. So they also transformed this facility into a hospital with 200 beds. Fortunately, these 200 beds are still not fully booked. It's about 50% occupied, and again, hopefully it looks like this is going to be enough. So the new problem now is we're seeing that our stroke patients that benefit from a stroke unit now, only because they have they are COVID positive. Sometimes they do not have a severe pneumonia, but they cannot be admitted into the stroke unit. And we have seen, of course, the problems that these patients are not managed as well outside of the stroke unit. So we are proposing to the management of the hospital to create or to duplicate a stroke unit, which would be a COVID positive stroke unit. And we are about to accomplish that. We'll have a duplicated stroke unit, one for COVID positive and one for non-COVID. And in fact, as of today, what we're doing, all these stroke patients are being admitted under the stroke unit team. So we are the attending physicians. We see them, they're spread around the hospital, and we're trying, as I said, to have them all in the same area and transform this area into a stroke unit with specialized stroke nurses, because this makes really a difference during admissions. So according to the number of admissions, here you can see what is happening. So another good thing that practice that the management of the hospital is doing is that every night at 6 p.m. there is a conference, an online conference by the management for all the hospital staff. Remember that many of the staff are either at home or you cannot do all these conferences anymore in the hospital. So everything went online, and the management speaks for the whole staff, and they update day after day about the number of admissions, the number of ICU admissions that you can see in yellow. Blue would be COVID patients. So at the peak, we had 630 COVID patients and about 200 ICU COVID patients. So almost 800 or 900 COVID patients only in our hospital. So we have daily information, which is very good. Also, another data that we know is that only, and I would say it was a topic that was controversial, but only 6% of the hospital workers have tested positive in the COVID test, which means that we are pretty well protected. I would say it's an acceptable rate. But it's also an interesting data that should be available for us, because we didn't have a shortage of severe shortage of masks and protection, but we were fearing that it could happen at some point. But fortunately, we had to be reasonable and not using them not using too many every day, but there was not a severe shortage. And the data that is a little bit disappointing the last 2 days is that you see here in these graphs the new diagnostics and the deaths. It looked like we went already through the worst part. But now we are seeing that in the last 2 days, there is again a slight increase. And this is what we are concerned about these last couple of days. So I think maybe we are a little relaxed as the society. Here I speak as a society. We were a little relaxed over the last week because we thought the worst was through. And apparently we should keep staying at home and being very strict with social life and social isolation, which is now we are on our fifth week of staying at home. Anyway, again, you see here that the expected numbers, we all the day see these graphs, so we're going to skip this one, but the point of this slide is to tell you that the number of ICU beds in my hospital was multiplied by 4. Usually we have around 100 or 75 stroke ICU beds. And we multiplied it in order to keep having available beds always. And another feature that is happening is that in the hospital, and most hospitals, they decided 3 weeks ago that to close it for all relatives and visits. So now the patients, they come to the hospital alone, and they are going to be during the whole admission completely alone. So nobody is allowed to come visit, and this is difficult when we need to get informed consents from the family, which is now not possible many times. And we need, of course, to give information over the phone every day. And also there's these sad situations when patients are going to pass away to die, and many times they are dying alone without any family near them, which is very difficult. So very difficult situation, but still we think that it is. We should not allow patients the families and relatives to come to the hospital, and it changes a lot the usual practice if you do not have a direct contact with the relatives. Another thing that we're seeing, and maybe you do not understand this newspaper heading here, but in Spanish, but it says that myocardial infarcts and strokes, the number of these patients seeing is decreasing. So these patients are not coming to the hospital mostly for several reasons. But in my opinion, the main reason why they are not coming is because they are scared. So we are not seeing anymore in the ERs mild strokes or TIAs. Those patients, probably they are terrified to consult and even to call 911 or the emergency services, and they are not calling, and therefore they are not coming. So the only patients that we are seeing in the emergency room is very severe strokes, and many times we see them later. So we started seeing those patients with very low aspect scores and large infarcts that we didn't see for as usually for the last years, because our systems of emergency works pretty well usually. And now maybe because either the patients are not calling, or there was at the point some kind of collapse of the emergency systems and they couldn't attend all these calls, we started seeing latecomers more often than usual. And here, from our registry, I just took the number of TPA cases and thrombectomy cases, and you can see the yellow progression over the last year, 2019, and in gray, the progression over the last month. And there is already, we can see already a drop in the number of TPA cases and the vascular treatments. Well, certainly because of the situation and the lockdown. So it's a fact that we are doing less treatments. We try to be as a Society of Neurology. This is a TV show from last night. I just took this picture, but my colleague here, Natalia, is the director of the Catalan stroke program. She is on TV telling everybody, all the population, that how important is, despite the COVID situation, to still consult if you have stroke symptoms or even myocardial infarct symptoms. You see, we try to do this population, to convince the population that they still need to call EMS. There are very few publications about what should be done during a stroke code during this era. This is from a very recent publication in which you can look for this publication in stroke, but it gives a nice example about how to proceed, about how to minimize the risks of contacts with patients and nurses and physicians, staying outside the room, favoring telemedicine consults or chats, video chats through your cell phone. And how you should, if unknown, at least with the prevalence that we have here, if the patient is unknown, his unknown status, we consider the patient as positive until it's confirmed negative, because even if with no symptoms initially, we do that, and we protect ourselves at the highest degree. Another publication about the relationship of COVID with stroke is this series of only 13 stroke cases out from 208 COVID patients. So meaning that 6%, around 5-6% of the COVID population presented a stroke, and the association was more frequent with severe COVID condition, and also, of course, obviously, if the patient had previously vascular risk factors. Another thing that is always cited in these publications is the D-dimer, which is higher in severe, I would say, in severe COVID condition, and it might be related to coagulation problems. But practically, there's not much we can do. Yes, we are not I don't see an advantage of monitoring the D-dimer in our patients once they have the stroke. They had it. Yes, we are now include this information in our lab tests, but I'm not sure what we're going to do with knowing that it's altered or high. Anyway, another very important feature, practical feature, is that using chest CT scans. We diagnosed many patients after clearly affected chest scans, as you see here, but also like in this case, in which you can see this hyperintensity here. Frequently, they are in the peripheral part of the lungs. This is kind of usual to see, as I've been told. And in this patient, for example, in this last patient on the right, after we saw this condensation here, we ordered the COVID test and the patient was positive. So since all stroke codes are going to the CT scan, so we agreed with radiologists that since they are already in the CT scan, and because the prevalence is so high, all of them would be screened with a chest CT, and this will help making the diagnostic of COVID. Because another thing that I would like to remind you is that the laboratory tests, they're at least the ones that we have here, are not very reliable either. And also I've read this on the literature, either because they are not 100% sensitive, and sometimes because the quality of the test or of the specimen that was taken from the patient is not good enough. But many times we repeated in patients in which we were convinced that they were COVID positive. First test was negative, second test was negative, and sometimes at third test we found out that the patient was positive. So tests are great, but you should not rely 100% on them because they are not 100% specific and sensitive. Another thing that we do here, as you say, everybody in the hospital, or most of us now put a plastic around our cell phone, and we throw the plastic when we go out from the hospital. So this is another practical issue that we are doing. Finally, so now we see in the hospital all these people dressed like this. This is our angio suite with we're taking the patient in here. As you see here, the patient was already intubated. It is a recommendation to intubate the patient before coming to the angio suite, if possible. Once the patient is intubated, the spreading of the virus is a minimum. So you minimize the chances to infect other people around. We don't always do that. It's not always possible, but this is one recommendation that can be followed. Of course, we still do not intubate all the patients or do all our thrombectomies under general anesthesia per protocol, but with these COVID positive patients, I think it might be a good idea, especially because of the data that I'm going to show you now. So here you see all these people so well dressed, but this was late at night, and sometimes because these equipments are so difficult to wear all these times, so you lower the bar and you take off your head protection, as you can see here, and it shouldn't be done. And this is me doing the case with these goggles. It's a real nightmare. And the N95 mask, you feel like there's lack of air, and in some cases I even had to stop in the middle and step back and breathe for a couple of minutes because it's really difficult. So our experience, since March 26, we did our first thrombectomy in a COVID positive patient. Since then, we did 16 thrombectomies in these 2 weeks, basically. And of them, 50% of the oral thrombectomies were COVID positive, and 5 of them died due to respiratory failure. So what we're seeing is that there is no increase in the rate of hemorrhages, neither with endovascular treatment or with IVTPA. In our series, we didn't see any hemorrhage. What we are seeing is a very bad outcome of these patients when they have a severe respiratory failure. And from these 8 thrombectomies that were positive, 5 died over the last the next days. So well, my interpretation of this data is that maybe we should reconsider in these cases in which they already have a severe pneumonia. Maybe the indication of a thrombectomy is well, we should reconsider it because their outcome is going to be very, very bad most of the times. But again, this is an initial thought after 2 weeks treating these patients. But again, there doesn't seem to be an increase in bleedings or hemorrhages in stroke patients with COVID. And I think this is what I wanted to share with you. And I saw that there are some questions on, or how should we proceed now? Okay.
All right. So we have to, Raj, you have to unmute yourself.
That was an excellent presentation, Dr. Ribo. Thank you very much. So there are a few questions, and so we will go through these questions one by one. Okay, I'll ask them for you so that it's easier. Are you able to see the question answers?
I can see it now. Yes.
So can I ask something first? I mean, Dr. Marc, you mentioned about CT chest. So are you doing CT chest in all your patients of stroke along with the whatever emergency radiology you're doing?
Yes, because and I think it depends on the prevalence. But here in a hospital in which 80% of the patients are COVID positive, it is very efficient since you already have the patient in the CT scan, just to take a chest CT there, because the patient is already there. You want to know if he's positive, because this may change the protocol for cleaning the room when he goes out, and you avoid the infection of the next patient. So it's for several reasons. In this scenario in which the prevalence is so high, we decided that it was worth to perform a chest CT to all the stroke codes that arrive, despite in the initial anamnesis, in the initial questions, you are not able to find signs that the patient might have a fever or short of breath. Anyway, we do that as per protocol.
Acha, I think there are questions there, and there are a few from Dr. Jayaraj Pandyan, and I think you must be aware he's one of the most renowned stroke neurologists in our country and all over the world. Raj, would you like to carry on?
So just before that, can I ask you if you have to do some contrast CT angiography? I mean, COVID patients are at high risk of renal dysfunction also. Do you wait for those, or you just go ahead and do a CT angio? What protocol do you follow in this patient?
Yeah, I know there is the concern about using contrast and renal failure due to but we to be honest, we're not taking this into account when we decide if the patient needs a CTA or not. Maybe we should, but I don't think I don't think it will make much of a difference. It might in most of the patients. Maybe in some of them only because of you did the CTA, you will induce a renal failure, but I don't. We are not taking this into account.
So how do you triage stroke patients in COVID hospital and send them to COVID area? This is from Dr. Jairaj Pandian from CMC Ludhiana. So what is the turnaround time for your COVID test? How long does it take for the report to come back?
Okay, we do the PCRs basically, and it takes 3-4 hours to know the results. In the meantime, so we have like in the hospital, like to make it short, we have like clean areas in which we are almost sure and the patients were negative, and we have positive areas, and we have these patients that remain in these intermediate areas until they have the test.
So if there is a patient with fever and stroke, where would you put that patient there?
So the patient comes to the ER usually, and if there is no sign of COVID, he will go to the clean area and be admitted in the stroke unit if he doesn't have any signs, and once but semi-isolated from the rest, let's say, and with additional measures until he's negative, and at that point we relax a little bit the measures.
I think that is very important, that we need a test which comes within few hours. At the moment, it's taking more time in our setups, so I think that will be critical.
It is critical. It's critical that it takes a few hours only, and not days. I've heard that in other parts of Spain it takes a couple of days, and this is crazy.
Yes, and I think there's another question from Dr. Jairaj about how did the infection, I think, reach Spain? Tourists from China, or how did it become so much? Yeah.
Probably, but the problem was more severe in the north of Italy at the beginning of March, before here. And the first cases that we had in Barcelona, they were from the north of Italy, for sure.
All right.
But then initially we were asking the people if they were coming from a high risk region or if they were travelers, but obviously not anymore. Now everywhere else they ask if they come from Barcelona, right? We are in the red area.
And
I have one question. Can I ask one question too?
Sure.
You talked about doing the screening for the patient using chest CT. We have thought of that too, but we haven't started. So maybe we will run into our first patient without knowing it. So when do you suggest we should start doing this chest CT as a screening process for the patients?
Listen, you probably take your patients to CT, and if it's a stroke patient or a stroke code, you do a CTA including the arch, right?
Yeah.
Or at least this is our usual protocol. We do a CTA starting from the aortic arch, and this is how we find out. Initially in this CTA, we found, and that was in one of the slides. We found these pneumonias in the higher part of the lungs, in the CTA. And then we decided, since we are here and we're taking half of the chest, let's do the whole chest. And it's a little bit more. Sometimes you can see these lesions in the lungs, in the lower part of the lungs, that otherwise you would have missed just in the upper part.
So that's the first case you ran into in March. You said March 26th. Okay.
That
so
was
by
the first lumpectomy, yes.
Yeah. So that's like you have in Spain like 57,000. I just checked on the internet. 50,000 cases, over 50,000 cases in Spain, and you got your first thrombectomy case. We're still at, like in India or in Japan, we are still at only have like 4,000 COVID patients right now. So maybe it's still a long way still we run for us to run into our first patient. I don't know if we should do the chest CT starting from tomorrow or wait until another 2 weeks. I don't know.
I think there are no right answers there, you know, I mean.
I don't think there are correct answers again. But another thing you need to take into account is comparisons between countries in terms of number of positives are not possible.
Yeah, it's not fair to compare.
On the availability of the test. If you have if you test everybody, you will have more positives than if you don't. So taking my numbers here in Barcelona and applying them to Japan, I'm not sure this would work because the prevalence is masked by the number of tests that are performed.
Yeah, so we will never know the exact number, but the purpose of testing the patients is to prevent us to get the disease and to prevent the infection to spread inside the hospital, right? So that's that's very important.
Yeah, basically because basically the importance of early diagnosis is to isolate the patient and avoid infection of other patients, and especially the healthcare providers, which at some point it was a really hot topic here, but apparently it looks like the numbers are telling us that we're protecting ourselves well.
So, Mark, there are 50 questions or so. So we'll have to just run through it. Okay. Do you think there is any difference in the pathophysiology or the possible mechanism of stroke between a COVID positive and a COVID negative sort of patient? Or do you think it is just the usual risk factors, but there is some hypercoagulable state and that is what is predisposing to it?
Okay.
Do you think there can be underlying vasculitis in these patients? What do you think?
Okay. In my short experience of 2 months, so I have several cases that clearly associated with COVID. One of them was the patient in which he had or turned out to have a chronic carotid occlusion that was stable, and because of the hypoxemia status and his pneumonia, he became symptomatic, and that was clearly a stroke but it was in a severe context of hypoxemia. Another patient in which clearly there is an association with COVID, the patient had an embolic stroke, but he also had this embolus in his fingertips with these hemorrhagic lesions under his nails, and clearly a high thrombosis status that was clearly related, probably related with the infection and with septic condition. So you can the mechanism of stroke can happen at least because of these two conditions.
So are you seeing any vasculitis in these patients? I mean, any more incidence of vasculitis by any chance?
No, I'm not. I cannot tell you. I haven't. Vasculitis is so unusual, and I haven't seen any case in the last weeks.
What is your impression on ACE inhibitors and in this patient's set of patients when they come in with a stroke? If they are on ACE inhibitors, do you stop them, move to a different one? What happens?
No, we were concerned, probably as you are and everybody else initially, because there were these news that there could be an interaction and maybe worsen the outcome. But we are following I believe the recommendations, not in which they say that there is not a negative interactions of ACE and the COVID disease.
And there's somebody who wants to know whether steroids will help in the management, like to prevent cytokine storm or something. I mean, do you think there's a role to play?
I don't know. I don't know. I'm not. I don't know. I don't know, and I'm not. I'm sure there is not evidence that supports that. Could be maybe as a because but.
All right.
Not sure.
And someone wants to know whether there is an increased risk of ICH in these patients by any chance. I think you mentioned that you haven't, but do you?
No, exactly. We have seen same rate of ICH over the last weeks, but none of them. Because I reviewed all our database, none of them was COVID positive. So no. And in the literature also, in this publication that I referenced from 200 COVID patients, 13 strokes, only one of them was an ICH. So apparently it's not increasing the risk.
If a patient has a severe stroke, but the COVID symptoms are less, say for example, you said that patients arrive late. So what is your cutoff on your core volume and other things? Do you do the best cases in this set of group, or how do you go about it?
Okay. Now this is now unrelated to COVID, right? Which is the threshold in aspects to indicate thrombectomy. So yes. Our protocol says with an aspects from 6 or higher, there is no doubt. With an aspects 3 to 5. We consider according to patient's status baseline, but obviously, and even more in this, if the patient is COVID positive and has an aspects of 3, I would be very reluctant to treat these patients. But again, it's on an individual basis, the decision is made in this 3 to 5.
I hope people have written questions, they understand that we are skipping a few which have been already being answered. All right. So I hope they understand that point where we are skipping some questions. So somebody has also asked about anticoagulation in this patient, like if there is more chance of thrombosis, should we use more anticoagulation in these patients? Anything like that? I mean, in stroke patients?
Okay. Yeah, there are publications that advocate in front of anticoagulate COVID patients as for prophylaxis because of this hypercoagulable state. And I think it applies to severe COVID conditions in which the coagulation system is altered. But again, it depends. I would not favor anticoagulation to all patients just because they are COVID positive, because we have also seen patients that had mild symptoms and certainly didn't need to be anticoagulated just for prophylactically so probably only in those who have a severe condition. This is under discussion.
One more question. Is there an increase in the number of primary hemorrhages, like hemorrhagic strokes, as compared to, I mean, you said the ischemic stroke part, but how about the hemorrhagic strokes?
No, there isn't. For sure, we haven't seen hemorrhages in COVID patients so far.
And somebody wants to know what does the rise in D dimer in stroke? I mean, what does it really indicate? I mean, how do you see it?
I don't know. I know it's. Well, I'm not an expert here in coagulation pathway but I know it indicates that there is a problem in the coagulation system, that an increased risk of thrombotic events also, there is some load of thrombus in the patient system, but it's very, to my knowledge, it's very, it's not specific at all. It just means that there is some coagulation problem, but not specific at all.
All right. And somebody wants to know, do you follow the same protocol for thrombolysis and thrombectomy as you were doing, or you have made any change in your protocols by any means?
No. We still do the same in terms of indications, in terms of the setting of the angio suite, and I always read here, yes. How do you clean the angio suite after? So if the patient is positive or unknown, there is a specific cleaning protocol, and the cleaning team comes after and does a full cleaning of the angio suite. But in terms of indications, so far we didn't change. But again, I think we should reconsider in those cases in which they already have very severe pneumonia, and on top of that, they have a stroke. It might mean that there's little to offer them, and the outcome is going to be very, very bad when the two things concur: a severe stroke and a severe pneumonia.
And someone wants to know whether there is more contrast-induced pulmonary edema in these patients when we do maybe CT angios, and more risk of pulmonary hemorrhage with IVTPA. Anything like that?
I haven't seen these. That's all I can say.
And how about patient transfers? If you have a suspected COVID or a COVID positive, what do you do for patient transfers once from the emergency to the CT and from CT to BSA?
Yeah,
are there any particular precautions?
For transport in the So have you seen in the picture in the angio suite, the people that transfer the patients they are completely covered with goggles and with this full body protection, and also the patient is completely covered wearing a mask, and so it's very spectacular.
And how about your lab? You have negative pressure? You have negative pressure?
No, we are not prepared for this. No. We don't have a negative pressure angio suite or no.
Okay, there's somebody, Dr. Santi, he seems to know you. He has asked you, hi Mark, Santi here. Did you notice a delay in the workflow?
Yes. Again, there is a delay in the workflow for several reasons, probably because patients are more reluctant to go to the hospital. So now we do have a case in which this is like the patient is, they consulted because the patient is still hemiplegic after 10 days at home. So they consult, they reached us by phone finally, and the wife told us that she didn't want to come to the hospital. She was expecting him to get better. But the patient is hemiplegic at home. So at this point, we just told her to stay. So this was like an extreme case. They were so terrified to consult that even after being hemiplegic, she didn't want to come. But again, we're seeing more patients with low aspects than ever, and practically very few cases with TIAs or minor strokes.
Have you seen any other atypical neurological presentations, which seems to be a recurring theme in the questions? Have you seen any Guillain-Barré type syndromes in these COVID patients?
No. It could. I know it's related to viruses, but not in this case. So I get people calling me because every little symptom in a patient that has COVID, they could be related. Today, somebody from a community hospital called me and asked me, the patient had this kind of aura in which she had numbness coming progressively and going away, and because she was COVID positive last week. Can this be related? I told him, I don't. No, we can try to. It's very early in the history of the disease. What we did here, the Neurological Society here, is set up a registry. So we are registering all these neurological conditions that happen in COVID positive patients, and we're going to see in a few weeks or months what we have in this registry. So we set up a registry. I think it's a good idea. Neurological signs in COVID positive patients.
And what about sanitizing the lab after this procedure? In acute stroke, you may not have the results and you have done the procedure. So are you sanitizing the lab after each emergency, or you have any protocol, and how are you doing it?
Okay, we tend to consider a patient positive as long as he is not negative. But of course, we tend to do that like this. So this would be the general message. So until it's not confirmed negative, you consider it a positive, and therefore you sanitize the angio suite anyway. Because you've seen from 50% of our thrombectomies were in confirmed positive patients. So in this scenario, you can sanitize after each thrombectomy.
And there is a question as to, have you stopped doing direct angios now, direct to lab? I mean, are you doing it, or all patients go to CT and then only? I mean,
no, we are randomizing patients in this study, and we try to with all our clinical trials, we in our center we perform a lot of clinical trials. We try to keep recruiting patients in clinical trials, So for example, I remember now a patient that went straight to the angio suite, direct to angio. What we did, we examined closely the chest X-ray on the table, and in that patient it seemed dirty, and the patient was then confirmed positive later.
All right. And are you seeing any more complications with use of thrombolytics or anticoagulants, or it remains the same in this COVID?
No, I don't have this feeling.
Yeah, Raj, carry on.
No, I was just, so 50% of your thrombectomies presented with a stroke to the hospital. That's what you're saying.
50% of our thrombectomies were COVID positive over the last 2-3 weeks.
So how often have you done a thrombectomy at presentation to the hospital, and that turned out to be a COVID positive patient?
No, well, I mean, so from the 8, we did 8 thrombectomies in COVID positive patients. I believe 2 or 3 were already admitted because of the COVID pneumonia, and the rest were coming as unknown and were diagnosed immediately or during the acute phase.
All right.
That's
Any
a high rate
on,
yeah, go ahead.
Any experience on venous thrombosis, cerebral?
No, we
because
didn't
I've heard,
last weeks. No.
I've heard 2 cases, one in New York and another one, I don't know where it was, but massive thrombosis in dural sinuses. So it might have a link with the D-dimer thing.
Yeah. Makes total sense, yes. Still,
Yeah.
and probably we will see a few.
Yeah, probably.
So you haven't thought about changing your protocol to MR because of COVID, to avoid CT angios? I mean, so there's a question like this. Or you're carrying on with the same protocol?
Why it would be better to do an MR here? It just
maybe even guy or something.
Sorry?
So you're doing the same protocol basically.
Basically the same, except that we expand the chest CT all the way down, instead of just the upper part in the CTA. We do a full chest CT in the same procedure.
Yeah, that's a very important point, because we usually do MRs for these patients, and we are thinking about switching to do only CT because we don't want to contaminate the MR room, you know.
That's a great reason not to do an MR. Exactly. I can imagine that decontaminating an MR is much more difficult, right?
Yeah, it's.
All right. And are you using PPE in all patients now, or only in COVID positive, or you're using it as a routine in your lab for all your patients?
Protection?
Yes, protection, yes.
You mean in the angio suite?
Yes, yes.
Yeah, in the angio suite, yeah. We so again, doing a procedure with all this covering is really painful, and well, we should apply the sentence that in case it's a known status, just consider it positive. But the truth is that my last case, it was unknown, but the degree of suspicion was low, and I just decided not to wear all these goggles and all the mask because it's really painful. I guess it depends on in these cases of uncertainty. It depends on yourself. But the recommendation would be, in case of unknown, just consider it positive.
Yeah, carry on. So I hope everybody realizes we are skipping a few questions which we think are answered, because we have still around 50 questions pending. So
I'm glad there is a lot of interest, and maybe I'm repeating myself, but no. If you can,
we are trying to avoid some questions because we think they have been answered in some way.
Yes.
So that if possible, we can cover all of them. So, so I think there's another question by Dr. Rajiv Anand, whether COVID is a viral septicemia, and whether the survival will be lower, and so should we opt for not non-interventional kind of management, So whether COVID positive patients have poor outcomes, so we should do less endarterectomy or less thrombolysis in these patients.
Yeah, that's. I think I tried to share this point before. Yeah, it's something to take into account. Maybe in these patients that they are having very bad outcomes and very low probability of survival. Therefore, yeah, we should really think twice before we do and it also depends on the resources, if the resources are unlimited or not. But sometimes you think it doesn't make sense to do a thrombectomy in a patient with such poor outcome.
There's a question here: whether do you have separate air conditioning in the COVID positive as compared to COVID negative? What do you do for the centralized air conditioning? Do you think there's a risk of transmission from one patient to another?
Yeah. So it happened to us that in our stroke units, the rooms are double rooms, and we had a patient that was infected by the neighbor, let's say, because we didn't know at that point that he was positive, and also two nurses from the stroke unit were. So that same patient infected in the hospital his neighbor patient and two nurses. So this is why it's important. It's important to isolate this patient, even if there's only a suspicious and not a confirmation. Before before it's confirmed. You should isolate the patients in which there is a suspected status. So it's really it's an infective. The degree of infective is high.
So there's a question from Canada. There's a question saying, did you or any member of your team become positive as a result of doing an EVT case on a positive patient?
Well, not in the angio suite, because maybe we are better protected. But as I just said, some of the members of the stroke unit, either neurologists or nurses, they were, and now they are at home for 15 days.
Yeah, Raj.
Yeah, I'm just scrolling through.
So somebody has asked whether there is any atypical vascular events. I think we have discussed this, but would you like to add something to it? I mean, atypical vascular.
What is atypical that I've seen is this emboli in the hand, this multiple emboli in this patient, which it's very rare to see. I've seen it before, of course, in endocarditis patients, but so I just saw it recently in a patient.
And Dr. Salja has asked a question that in this very early phase of COVID, did you do any rapid testing in the ER before taking up patients, or you just take them up? I mean,
we don't have availability of these rapid tests, these antigenic tests in the hospital. It's a big political issue with the tests, and I'm sure everywhere. And so they are not available everywhere. Now they're favoring them for. So a big problem here is nursing homes. There were lots of deaths in nursing homes and lots of infected older people. And now apparently these rapid tests are being used or are going to be used in nursing homes, where they apparently are more needed.
So there's a question about anything you've learned from your autopsies in these patients. I mean, has anybody had an autopsy and any autopsy studies that have given some light on what is going on in these patients?
No, I'm not aware that we have done any autopsy in none of these patients. So no. The answer would be no.
and there's a question that can a patient of COVID present with only neurological manifestations? I mean, are you seeing that as a neurologist?
Okay, an interesting case is one of my colleagues from the stroke unit. She's a neurologist, and she find out that she's positive because she stopped smelling. She was changing the diapers of her baby, and she realized that she had anosmia. She could not smell the bad smell of the diapers. And this is known to be one of the symptoms, the lack of smell. So she asked to be tested, and she turned out to be positive. But her only symptom was anosmia.
And there's a question. I mean, you already mentioned that how a patient with severe pneumonia and they didn't do well after thrombectomy. So now you have developed some protocol, how severe a COVID patient you should intervene and you will hold back. Is there any limit to it? And how do we decide upon that?
Okay, we don't know. And okay, so put yourself in our position in which everything is unknown here. And it was in 3 weeks, we went to a scenario in which everything is so strange here. Again, the hospital looks completely different. The hospital is empty everywhere. There's no patients. Everybody's terrified to go to the hospital. Only patients in the rooms. Nobody walks in the hallways. The cafeterias are closed. Obviously, everything is closed. When you cross next to somebody, you avoid him and you keep 2 meters distance. Everybody's with masks. So it's a complete change in everything. And it's very early to decide if how we can change the protocols, or if we should limit the care to these patients with severe pneumonia. We probably should, but it's very early. Again, we just did a few thrombocytomies. Is this going to last a long time, or is it going to be over in 1 month? That's another thing we don't know. Maybe this is, hopefully it's going to take only one month, and in a few weeks we're going to forget about it. I don't know all these answers, and it is being difficult to take definitive changes in the protocols or answers with in which we can be 100% sure of what we're saying. So again, my presentation here today is to try to give you some clues and personal tips from my personal experience, but don't take it as data which is backed by scientific evidence. It's most of the times it's my personal experience over the last 2-3 weeks.
Understand, I'm sure, I mean, you're going through very tough time, and we're just, when you mentioned about hospital, we're just beginning to feel so, going to hospital and starting to play on our mind. I can imagine, I guess there are a lot of questions because everybody is very curious to get whatever information they can get from you. And and that is why we are asking some of things repeatedly, so that, people are satisfied. Raj,
Mark, how often do you see myocardial problems, like myocardial injury and rhythm abnormalities in this set of patients? Is that a problem, or?
As a stroke interventionalist, I don't think that. I'm sure there are, and I know in the medication they give to these patients, they take into consideration the QT interval, but I'm not. I don't want to go this way because I'm kind of ignorant in this field, and I'm not the person to you should ask.
Most of them are repetition of the same questions, I think. Dr. Kittipong, do you want to ask? You want to share something from your end?
Yeah, it was really impressive to see your slide showing the hospital being filled with COVID patients, like 80%. And we still need the stroke unit, right? So the demand of the stroke unit and the team that has to be functional all during this crisis is very impressive to me. And we have to keep ourselves from being infected, and at the same time we have to give these treatments to the patients. It was so impressive.
And
so this is exactly, I feel that many patients, because of the COVID situation, they don't have access to their specialist, and the stroke case is a paradigmatic. Stroke patients benefit from being in a stroke unit, and only because they have COVID, it doesn't mean they should be taken away from this benefit. And this is happening now. We're seeing these stroke patients that are admitted in, but this is because in the middle of the chaos, you cannot, you should lower the bar of the bar, and you cannot give the same degree of excellent attention.
So what about other emergency patients, like traffic accidents? You still take care of those patients in your hospital?
I'm sure the same happens for all other disease, all other concomitant disease. The access to a specialist is much more difficult because everything is contaminated again by not only literally, but contaminated by the situation that COVID has taken everything, and is the priority only to cover COVID and to isolate these patients. And so therefore, other things became secondary, and that's a problem. I know the problem with stroke, but I'm sure it happens with probably with MI or with traumas or any other condition.
Yeah, and probably like 1 month ago, probably you didn't expect anything like this, and yeah, we hope we won't have the same issue the next month, but it probably definitely is going to happen. Yeah, it was very nice sharing your experience to all of us. It was very helpful.
Okay, I'm glad I could help somehow, and yes, I hope you don't get here, but this is what we thought a month ago when we heard about China, and now we are here. So hopefully it doesn't go everywhere as bad.
One short question. There was a question there in terms of disinfection of DSA lab. Is there any special protocol you are following, or your department is following, or is just these?
The disinfection of which lab?
DSA, the cath lab.
Yes, the cath lab. Yes, there is a specific cleaning protocol. I cannot tell you exactly which is the product that they are using. Sorry, but there is we were all trained. First, we were all trained to how to get dressed and covered. We performed some videos, and if you want this video, if somebody emails me, I can share you these videos. But how specifically to put your goggles, your masks, and to take them off. But also for the cleaning squad, they have their protocols with special I don't know disinfectants, which I cannot tell you which, but they come after we finish and they do a full cleaning with of everything.
Yeah,
How long do you wait until you start the next exam? You mean the air?
Yeah.
2 hours?
We need to wait for 2 hours. Yes.
Okay.
So I can imagine, because in India, a lot of people are working in small hospitals, and they may not have a very clear protocol how to handle this. So I think that's why that question came up. I can imagine many interventionists are pretty worried as to how to handle the situation. So I thought that I would ask it. So Raj, you want to ask?
Just one last question. Is there any role for prophylaxis, or any of your medical professionals who are actually in the respiratory team at least taking any prophylaxis in terms of HCQ?
No, I'm not aware that there is an evidence that there is a prophylaxis that works, right?
I agree.
And we are not taking. I heard of nasal sprays, but I'm not taking it. I don't know anybody who's taking it. I've heard, but maybe also I think it's not proven to be effective.
Okay, I think
the questions are all done.
Yes.
And thank you.
Yeah.
Thank you.
Hi, Dr. Rajsrinivas. This is Rajneet here. Yeah. So we have received many requests, like doctors are asking if they can have the presentation, and this would be like helpful them. This could be like some way useful to them. So if Dr. Marc is okay, and you can share your presentation later to Dr. Rajsrinivas, so that can be shared with the attendees. I mean, if that is like, or if you are fine with it.
The video is recorded. Sure. Rajneet,
sure.
So if your Marc is okay with it, this video recording of this session, and that we can put it up on YouTube and send a link to everybody. I mean, I think that if Dr. Marc is okay with it, that will be more convenient. It will have all the questions, answers, all discussion within it as well,
Sure. That would be better. Yes, definitely.
Okay. And one last question, if may I ask, Raj, you want to ask about ACE inhibitors, whether
I've
already discussed, right?
Yes.
So Raj, would you like to?
So I mean, Marc had readily agreed for this actual session. I really thank him for that, and I've troubled him in the past also, and maybe I'll be troubling him in future also. Thank you very much for attending, and I'd like to thank Dr. Kittipong also at such short notice. He had agreed to be a co-host in this particular session. And thank you very much for that as well.
And my best wishes for
Thank
Spain.
you to you.
And everybody there. I hope things settle down, you know. So this is really united world. Everybody is ready for each other, you know. What happens there matters here and everywhere else. So I think that way we are all connected. And I just hope, we cannot imagine what tough time you have gone through and going through. I just hope things settle down. Yes. And
thank you. Thanks everybody. And all the audience. We had a large audience, I can see. And
I think more than 500 people were there, neurologists. So that was terrific. And interventionists. Yes.
Great.
Yeah,
take care.
Thank you very much.
Thank you. And thanks everybody who has attended. You're taking time out. And for all the questions which came in and Dr. Mark took trouble to answer, it was a very satisfying session. Thanks a lot.
Yeah, great. Thank you very much, Mark. And thank you, Dr. Kittipong. Yeah, great. Bye.
Thank you.
Okay.
Yeah.
I'm closing the meeting now.
Thank
you very much.
And, okay, I should have thanked, Rajneet, for you guys helping us out to organize this. And I should have done it before we close the meeting, but thanks a lot for the effort.
Sure. Yeah. Welcome. I'm closing now. Bye.
Okay,
all right.
bye-bye.
Thank you very much.
Bye-bye.